Welcome to the Jerry Pal Podcast. This is Eric Widera.
This is Alex Smith.
And Alex, who is our guest today?
Today we have a palliative care superstar.
Guru
superstar on the line. All of her sessions at the annual Academy meeting, AHPM HIPNA, are packed, sold out, standing room only. Welcome to the Jerry Pal Podcast, Lynn McPherson. Lynn is a professor at the University of Maryland, School of Pharmacy, and program director of the Masters of Science in Palliative Care at the University of Maryland. Thank you so much for joining.
Thank you for having me. It's a pleasure to join you two rock stars.
I am so excited about this podcast. I love going to every one of your sessions. I learned a ton.
Thank you, especially the good jokes, right?
And I'm actually really excited because I just finished reading your book, Demystifying Opioid Conversion Calculations, a guide for effective dosing, that just came out. Is that right, Lynn?
It did about a week ago.
Wonderful. So we'll talk a little bit about the book, but before we go into the meat of this podcast, Lynn, do you have a song request for Alex?
Well, I'm a big fan of Huey Lewis and the News. I Want a New Drug.
Good choice. I want a new drug that won't make me sick. One that won't make me crash my car, won't make me feel 3 feet thick. I want a new drug that won't hurt my head. One that won't make my mouth too dry, won't make my eyes too red. One that won't make me nervous, wondering what to do. One that makes me feel like I feel when I'm with you. When I'm alone with you.
Alex alone with his opioids.
Wow. Move over, Huey. You nailed it.
That was great, Alex. Well done.
Very good.
Thank you.
I'm always impressed. Every time, another new drug or another new song. And you just...
It's a good challenge.
Good challenge.
It's a lot of fun.
Well, then, a very big thank you for coming on. And we're going to be talking a little bit about opioids during this time and opioid conversion calculations and a little bit about your book. Before we kind of jump into this, let's talk for a second about your book. So because I can only imagine the amount of work that you put into this book. Like, why did you do it?
Well, probably there's psychopathology at work here, but the whole thing started about 10 years ago when I was searching for a good resource on opioid conversion calculations, and I kept beating my head on the table saying there's got to be something out there, and there wasn't. So I thought, well, you know what? Maybe I'll just do it. So I spent a year, every time I gave a lecture, I developed a survey instrument, and I would give it to the audience saying, do you think this is a great idea? What would you like to see included? And then, coincidentally, an editor from the American Society of Health Systems Pharmacists had emailed all the faculty at my school right before the holiday break and said, look, I'm going to be in your building. Does anyone have any good ideas for a book? So I wrote back and said, I do. Why don't you contact me in January? So she called me within about 15 seconds and said, you can't do that to an acquisitions editor. And that's what got the whole thing started.
Wonderful. How long did it take you to write the book?
Oh, way longer than the publisher would have liked. The first edition took about 2 years, I would say, because I have a lot else going on. But this was really hard to do because there's, as you know, very well know, there's very little consensus. And then with the second edition, which I was longer getting that done than they would have liked as well. But to my benefit, I think, and to the benefit of the book, we're finally getting better data about doing these calculations. So I think it significantly better informed the second edition. So I was really pleased with it.
That's wonderful. I wonder if you could tell us, like, what's the number one most common question that you get about opioid conversions?
Well, I think there are always questions about methadone dosing. That's probably the drug that scares people the most. But other than that, it's kind of all over the place. Like I was just in Texas at MD Anderson giving a lecture on opioid conversions, and one of the physicians asked about, now that we're getting better data looking at steady state conversions as opposed to single dose crossover trials in healthy normal people, do you still have to reduce for cross tolerance? And you don't, but that raises the question, how do you know from those equally analgesic tables when when you do have to reduce and when you don't need to reduce. So I think people are very confused about that. When do I need to reduce for lack of cross tolerance? Which really it's a much more complicated question. Is the patient in pain? Is the patient not in pain? What's their clinical situation? So this is why I rabidly despise apps for opioid conversion calculations, because it lets you shut off your brain and you just don't even question the number and you just roll with it. And people tend to make egregious errors by using an app.
So that was actually one of our questions. Can't we just use an app? It sounds like you just answered that for us.
You cannot. You will get in big trouble. I had a pharmacy student once on rotation, and a nurse asked me to do a conversion. So I turned to a junior and I said, hey, this is great. You do the calculation for the nurse. So he said, oh, I've got an app for that. I said, of course you do. So he whips out his phone. He does the calculation, and he goes, wow. I said, what? Wow. He said, it came out to like 5,000 milligrams of morphine. So I said, well, what do you think of that? He said, well, we're going to have to order more morphine. What a monkey.
So, going back to kind of how you've outlined in this book, that the very first chapter is, if we're not going to use an app, we go to our handy dandy trusty opioid conversion tables, equal analgesic tables. What are the issues that you have with opioid conversion tables? And yours looks a little different, too, than the ones I've seen.
It very much is different. Yes, it is. So I think the bigger issues is with the first edition of this book, my table looked very similar to the tables that are still out there today, where you would say, for example, that 1.5 milligrams of IV hydromorphone is 7.5 milligrams oral, which is 30 milligrams of oral morphine. So if you went from IV dilaudid to oral morphine, you would multiply by 20. That was based on single-dose acute pain crossover trials, mostly in healthy normal people. So most of the tables that are out there do not account for patients young, the patient's old, the patient's in the pink of health, the patient is sick. They're skinny, they're fluffy. It takes no account patient-specific variables, I would say. But now we do have some data that's starting to emerge. So Dr. Akila Reddy from MD Anderson has done several studies looking at IV hydromorphone to oral opioids. She's looked at hydrocodone to morphine more carefully, transdermal fentanyl. So this data is finally starting to come out, but it still requires caution in using these charts. If you read the book, you remember the line where I said, using one of these charts is like giving you a ticket to the ballpark, but you still don't know exactly which of the 40,000 seats is your seat. You still have to use your brain and your clinical acumen to decide how to go with this. And I am a board-certified card-carrying weenie when it comes to this scheduled around-the-clock dose of the opioid that I've just calculated, but I'm insanely generous with the breakthrough because I don't want anyone to suffer because I'm a big weenie.
Okay, so wait, I'm going to take a step back. I shouldn't be using 1.5 of hydromorphone to 7.5 of hydromorphone.
No, because if you look at data that's actually quite old, the bioavailability is about 50%. So you're right. My new chart, I think, is going to cause quite a stir because I have that for hydromorphone, 2 milligrams IV is 5 milligrams oral, which is much closer to the numerous studies we have showing the bioavailability really is about 50%, although there is quite a wide range. Also, I lowered the equivalent to oral morphine from 30 to 25 because Dr. Reddy's data showed that it's about 10 or 11, 12 times the potency of IV dilaudid when you're switching to oral morphine. So the chart still works. Everybody's got their own chart. But frankly, my chart is based on the very, very latest, best evidence available.
Okay, so this is my challenge with looking at all of this new data, because most of the new random trials of this is looking at going from, let's say, hydromorphone IV to PO, but not the other way around. And then there's another study that looks at it going other way around. And same thing with like when we're looking at like morphine or morphine to something else, is that like how should we like, is the equal analgesic table just has it lost its time? Should we move on to something else? Because going from one drug to another drug in one direction may not be the same as going from that same drug from the new drug back to the old drug.
So you're questioning bidirectionality.
Yes.
And in fact, with the IV hydromorphone to oral morphine, Dr. Reddy did look at that, and she did show bidirectionality. But when you look at data looking at IV or sub-Q morphine to IV or sub-Q hydromorphone or oral morphine or hydromorphone, those old studies show that it's not quite as bidirectional as you would think. So in the charts, what people have done is kind of split the difference. So, I know my pharmacy students, when they see a chart like this and we talk about drug math, they get very excited because they think there's one right answer. But that's the whole point. I actually flirted with doing away with the chart, as you just suggested, or instead of putting a number in there, putting in a range, like, 2 milligrams of IV Dilaudid is somewhere between 20 and 30 milligrams of oral morphine. But I think that would confuse people even more. So I chose to stick with the very best number from the data that I could find and come up with a 5-step process that I strongly advocate, which calls for people to use their brain and interpret that number. When you calculate a number, you can either go with that number, reduce it, or increase it. That's where the thought process comes in.
I was told I did not have to use my brain in medicine.
I heard that, but they were wrong. They pulled your good leg there, dude.
Or at least math. 5 steps. So can you just kind of briefly go over, what are the 5 steps that you're advocating?
Sure. So the first step, and this makes nurses crazy when they call me because they say, why can't you just answer the question instead of asking me all these questions? The first step is to carefully assess the complaint of pain, because sometimes the answer is not to switch opioids. Sometimes the answer is you just need to increase the opioid they're on, or maybe you need to add a co-analgesic. So it is doing a complete assessment of the pain, and you're going to need that data in step number 4. So stay tuned on that.
Wait,
Step
can I
number-
stop? Hold on. What, it's just along the lines of that first step there? When you say co-analgesic, are you talking about a second opioid, or are you talking about adding adjuvant?
Adding an adjuvant drug, yes.
Right. So you do not advocate. We have, for example, I know several clinicians who swear by having people on multiple different long-acting opioids.
No, I don't buy that at all. I don't think that we have data to support that, looking at the way different ligands bind. I don't think we're there right now. The only time I would ever recommend using an opioid adjunctively is perhaps using baby low-dose methadone on top of a more complex regimen. It seems sometimes, and the data, again, is not very thick on the ground there either, that adding a little baby low-dose methadone on top of the whole red-hot mess due to NMDA receptor antagonism can be a beautiful thing. But no, I don't agree with using 2 long-actings. I think you're just looking for trouble.
Great. So, sorry, I was interrupted you. Step 1 is consider increasing the opioid you're on rather than switching or adding a
right, making sure that doing the conversion is the correct therapeutic thing to do.
Okay.
So let's say you decide, yep, that's the right course of action. Step number 2 is to calculate the total daily dose of what the patient is currently getting. So if they're getting oral long-acting plus breakthrough, and you've got to be careful there because often people will tell me, they're on MS-Contin 30Q12 with Roxanol 10Q2 PRN, and I'll say, how much are they using of the PRN? I just told you, 10Q2. I said, no, you told me the order. You didn't tell me how much the patient is getting.
Right.
If you don't know how much the patient is getting, just leave it out of the equation. So you want to really be comfortable with the total daily dose of the current opioid the patient is receiving.
And I loved in your book, you also said, just because somebody says they're using it Q2 hours, that PRN, doesn't mean they're actually using it because they may be sleeping.
Yes.
So really thinking about using diaries to help document when they're using these PRNs instead of just saying, they're using Q2, so that's 12 doses a day. But probably they're sleeping somewhere in the day.
Absolutely. So if you do have the luxury of in a nursing home or assisted living, looking at an MAR, a medication administration record, or if the patient is at home, if they're keeping any diaries themselves, that's very beneficial. But if it looks a little fishy, don't even include it. Very important. Mm-hmm. Then step 3 is the one that makes everybody want to, have a seizure, which is the actual ratio. So the way I set up this equation is I put my everything on the left side of the ratio is real-time data. I put my unknown in the numerator, X milligrams of my new opioid by the preferred route of administration over the current opioid by whatever route of administration the patient is getting it. Everything from the right-hand side comes from the equianalgesic table. You will see the same opioid by the same route in the numerator on both sides, and similarly in the denominator on both sides. You cross multiply, you solve for X. That's step 3. You've got this number. And now what do you do with this number? That's
wait. So on step 3, sorry to interrupt, you do not advocate converting to morphine equivalents and then converting from morphine equivalents to the new opioid every time.
I do not.
You do
No,
not.
I never do that. But if you are a doubting Thomas, you can certainly do that to prove to yourself you'll get the same number.
Or likely that you will just mess up on the additional math steps.
Well, I'll
There
tell
you
you why
go.
I do that. I was trained to do that, but and it's largely because I think in morphine equivalents. Like if I need to know, is that a lot or a little? I can't answer that question as well with the other opioids, but I can answer that with morphine.
That's fair. That's fair. But check your math and make sure you're doing the direct conversion appropriately too. I do think that increases the margin of error, but fair point. All right, so now you've got the number, the magic number. Step 4 is to revisit what was going on in step 1. Is the patient in pain at the time? Why are we switching? Are we switching because they were having uncontrolled pain, but yet you continue to believe an opioid is appropriate therapy? Maybe you need to be a little more aggressive. Maybe you're switching because now the patient can't swallow tablets or capsules anymore, but they were very, very comfortable. Maybe you're switching for whatever the reason may be. So then you have to take into consideration, what am I going to do with this number? Generally, you don't roll with that number. For one thing, it's probably a goofy number that you can't actually do with tablets and capsules that are commercially available if it's the oral route of administration. If a patient was switching because of a side effect and their pain was well controlled, another important consideration is, are you switching from one opioid to a different opioid? So if you're going to a different molecule, they will be more sensitive to the new molecule, so you probably should reduce it. Now, as I said earlier, what's confounding the situation is we have steady state data looking at going from IV Dilaudid to oral morphine, for example, which kind of took into consideration that lack of complete cross tolerance. So I probably would not cut back as much, but this is where you have to put on your thinking cap. Sometimes I'll reduce that by 50%. Sometimes I'll reduce it by maybe 15%. Rule of thumb is about a third. And then I'm very... Go ahead.
Going back to steady state. So if somebody, let's say somebody's gotten more than 5 doses. Wait, I'm trying to think back. So steady state happens after
5 half-lives.
5 half-lives. Somebody's been past 5 half-lives. Their conversion's going to be different than somebody who is...
No, that's not what I mean.
Okay.
I'm talking about the evidence that we have when those clinical trials were done on patients who were at steady state. That data is more reliable in terms of how much do I really need to dose reduce. But if it's not, and we're looking at data, for example, conversions where we don't have that kind of data, I would tend to cut back even more.
Well, this is wonderful. But on the same note here, how long is the issue that they've achieved steady state with the opioid, and at that point we should be thinking about dose reducing for incomplete cross tolerance, like immediately after they've had 5 doses? Or is it something about the chronicity of, they've been taking it for weeks or days or months, and we should have greater consideration for incomplete cross tolerance?
Well, I think one thing you have to be concerned about is that they've been on this same opioid regimen for a good while, and now they're not responding as well. You have to give some thought about tolerance. So that's why when you switch to a different molecule, you really do need to cut back because they're going to be more sensitive to the new molecule despite doing the math correctly.
Right. So the incomplete tolerance, cross-tolerance issue only comes up once they're tolerant, which is something that happens over the course of weeks to months, right? Not necessarily days.
I don't think we can necessarily say that either. I think anytime, the current thinking is we have 25 different kinds of mu receptors, which is crazy pants. But maybe in you, oxycodone binds a little bit differently than morphine or than hydromorphone or than hydrocodone. So it could be after 1 dose, for example, or 2 doses. You could be short of steady state and still you could have binding differences when you're switching opioids. So all I'm saying is when you're switching from one opioid to another, it's a muddier picture than if you were going from IV hydromorphone to oral hydromorphone, because once you get the drug into the systemic circulation, hydromorphone is hydromorphone, whether you put it in rectally or IV or orally. See what I mean?
Yeah, that's terrific. This is so good. This is
okay.
Go
ahead.
All right, wait. I'm going to go back because I don't want to forget the steps. So we're going to assess the patient. Step 1. 2, we're going to determine the total daily dose of the current opioid. 3, we're going to decide which opioid analgesic to use.
And do your ratio
and
conversion.
do our ratios. Then we're going to individualize the dosing based on what we gathered in step 1. That's step 4, right?
right? So let me tell one more thing about 4, and then we'll do 5.
Okay.
So let's say you're switching from Dilaudid to morphine, for example. So you want to cut back because of lack of cross tolerance, but the patient was in a ton of pain. I think that also factors into your decision. While you might cut back some, you wouldn't cut back as much than if the patient were very, very well controlled and, in fact, a little bit sedated. So you have to take all that into consideration. Then step 5 is the most important step of all. It is monitoring your patient like nobody's business, because you probably will be off a seat or two in the ballpark. So you can't just do this and walk away. So you have to be very careful to, like, I'm very fond of asking patients to rate their pain before they take a dose of breakthrough and 1 hour later, because you peak on your morphine or oxycodone or hydromorphone by about 40, 45 minutes. So at 1 hour, that's as good as it's going to get. And then I watch how they do over the next 12 to 24 hours, maybe 48, and then I can adjust things so the patient can take the fewest doses of breakthrough possible.
All right, when you said the most important step, I thought it was billing, but no. Step 5 is
Step 6 is billing.
That's step 6. That'll be in edition 3, version 3 of the book.
okay. Going back to like when we're deciding to which opioid to choose. Like for folks with liver failure, let's say. Are there any preferences in individuals with liver failure?
Nope. All the opioids are handled by the liver. So I think I would be very, very leery about methadone, particularly if it's somebody with end-stage cirrhosis, because that's going to take a long time to get to steady state. But all the opioids are handled by the liver. I think you have a little more flexibility in making better choices when the person has renal impairment, because methadone, we believe its main metabolite, is largely pharmacologically inactive, although there's a hint of data now that perhaps that metabolite may be the culpable agent with QTC prolongation, but for intents and purposes, let's say they're pharmacologically inactive, as are the metabolites of fentanyl. So those would be better choices of people with significant renal impairment.
Okay, we're avoiding morphine, hydrocodone, and codeine. What about like?
We're talking about in renal failure now. We've gone from liver.
We've switched organs.
So liver is just backing up. I just want to clarify: liver avoiding methadone, but all others start low, go slow.
Oh, all of them, absolutely. So all the opioids are handled by the liver. The most problematic in my mind is going to be the methadone, because it could take you 2 weeks to get to steady state with an incompetent liver.
Got it. And then when we move on, talk about the kidneys and renal issues, people with chronic renal disease, acute renal issues, then we're talking about avoiding. You were just going to say, Eric, you were going to ask.
I always was taught like morphine and similar things like hydrocodone and codeine we just avoid all the time. We had a great episode on tramadol or tramadont that I encourage our listeners to listen to.
But in terms of the other opioids,
what about like oxycodone and hydromorphone? I know we use a lot of that.
And fentanyl.
Fentanyl, we just heard that fentanyl and methadone are the safest probably, but this middle ground.
Yeah.
What are your thoughts about those?
I'll tell you, I think the naughtiest kittens are clearly morphine, but I think hydromorphone is almost just as bad. And I know prescribers think that hydromorphone is such a clean drug, but both morphine and hydromorphone are metabolized to a 3-glucuronide metabolite. And that's the bad boy that accumulates and can cause opioid-induced hyperalgesia.
Metabolized in the kidneys.
By the liver, and then but it's a pharmacologically active metabolite that relies on renal excretion. So if you have bad kidneys, that sucker is going to accumulate and can cause hyperalgesia. It can cause muscle twitching, seizures, coma, even death. Not a good look. I think the best are going to be the fentanyl and the methadone, and frankly, the rest, the hydrocodone and the oxycodone, are in the middle. They're in the middle of the pack.
Oh,
that's what I think. Okay. Yeah.
Okay.
We're going to need a second podcast. So many questions. This is great.
So would you advocate for avoiding hydromorphone like we avoid morphine in renal failure?
You know, I do think it's almost as bad as morphine. I think morphine is still the worst. And people, you'll see on listservs, like, what's the creatinine clearance cutoff for using morphine or hydromorphone? And I think that's kind of a subjective question, because it's kind of like a three-sided graph, because it depends on how much of the opioid they're getting per day and how bad their renal function is. So, for example, if I had really bad renal function, but I only took morphine 5 milligrams orally once a day, that's not that big of a deal, because even if it takes 24 hours to get the metabolites out of my body, it's okay. But if it was taking a higher dose and taking it more frequently, then it becomes more of an issue. And the Idomorphone.
This is terrific. So here's, we've talked about liver disease, opioids and liver disease, opioids and renal disease. Could we talk about opioids in older adults?
Of course. So we do know that older adults, when you look at differences between older adults and younger people, there is a pharmacodynamic difference. So older adults are more sensitive overall to the effects of the opioid. Just last week, a physician asked me for a starting dose of methadone in an opioid-naive patient, which we actually do in hospice, and that makes a lot of people uncomfortable. And this doctor started the patient on methadone at 0.5 milligrams Q12. And I wrote back and I said, I think we can be a little more aggressive and do 1 Q12. They emailed me back day 2 and said, oh my gosh, it's a miracle. She's completely pain-free.
Wow.
That's not a good look either, though. With methadone, you don't want to be a rock star on day 2.
Right.
You don't want to be a rock star until day 4 or 5. So I was like, wow, now we have to watch her for accumulating sedation.
Right. That is amazing.
It was amazing.
Such a low dose.
I know, it's like licking the bottle. You know what I mean?
Right.
Okay. I'd like to ask you a little bit more, sticking on this drugs, but actually moving away with type of drugs to administration of drugs. Mm-hmm. Like we use a lot of sublingual morphine, Roxanol, the version that we have here. Does it get absorbed sublingually, or is that an old wives' tale and it just drops down to the gut and you absorb it usually?
That's a fabulous question. When I think about the most important drugs in hospice and palliative care, I always talk about my 6-pack, which are the intensols. So an intensol is a high concentrate oral solution of a medication. So we have morphine and oxycodone 20-1. We have methadone 10-1. We have haloperidol. We have alprazolam, prednisone, dexamethasone. These are the drugs we use over and over again. And I see patients who are no longer cognitively intact or they're unable to swallow. Even if someone is completely unconscious, you can prop their upper body up 30 degrees and put up to 1 ml in the buccal cavity. So what happens? That's a great question. It depends on how water or fat soluble the drug is. So for example, morphine is the most water soluble of all the opioids. So only about 20% of that dose gets transmucosally absorbed. But that's okay. Kind of hangs in the buccal cavity there and trickles down the throat very slowly, just like they had swallowed it, which is fine. That's perfectly fine. You look at a drug like fentanyl, which is one of the most lipid-soluble drugs, probably closer to 50% of that drug gets absorbed transmucosally, which is why we have 6 transmucosal fentanyl products on the market, because you have better absorption because of the lipid solubility.
All right, I got another question based on that. Is because we're talking about lipids, fentanyl transmucosal, and oh my God, they have no subcutaneous fat. We can't give it to them because it won't be absorbed. Thoughts on that statement?
Well, we do know clinically and anecdotally that people who are very wasted and cachectic, if you use transdermal fentanyl, they really don't seem to get the bang for the buck that you would expect. There's some data from Norwegian country, for example. But why is this? And we're not 100% sure. It could be that, being a very fat-soluble drug, if somebody's skin and bones literally, can you find a little fat pad to apply the patch? That may be part of it. It may be partly the drug. What does get absorbed kind of looks around and sees it's got nowhere to hang and says, well, I guess I'll get out of Dodge now. But we also know, for example, that cancer patients, the fentanyl is pretty highly bound to albumin. And with cancer, the fentanyl-albumin combination goes into the extravascular space and hangs. So it's not in the central circulation available to bind to the mu receptor in the central nervous system. So I think there's a lot going on. I think the biggest admonition that I would share is if you have someone on transdermal fentanyl and you know in your heart this is just not working out, you don't go from 25 to 50 to 75 to 100 and say, well, this isn't working. I better take that 100 mic patch, and I know that's equivalent to 200 of oral morphine. I'm just going to switch to oral morphine.
Right.
You should never do that. Go back to the last strength that worked, and if you can't find any strength that worked, pretend they were opioid naive and start from scratch.
And I really like the figure in your book too, because when in the chapter about fentanyl, it clearly shows is that it's the microcirculation in the upper dermis, the microcirculation in the cutaneous area that matters. It's not that deep, fat pad area where it's going to be absorbed.
Right. Which leads me to another question about fentanyl. I was taught that in the setting of person who's on a fentanyl patch who's getting a fever, you should rip off the patch because that fentanyl is going to be absorbed more rapidly and not in a reliable way.
Well, we do know. Well, if somebody has a fever about 104 or so, you can increase fentanyl absorption by 30%. I think the biggest point to take home from that is I took care of a gentleman who was a construction worker and had a concrete ceiling collapse on him and obliterate his right hip. So it was rebuilt, but it left him with horrible pain. So he was on transdermal fentanyl for his pain, which he insisted on putting on the hip because I could not disavow him of the notion that the drug didn't actually get sucked right into his hip. But the third day he ran out of steam. So he said, don't worry about it, though. I just put a heating pad over it and it all works out. Well, I almost had a stroke. So we do know that about 20% of people can't go 72 hours. So 20% of folks, we've got to go Q48.
And I also loved in your book, you also talked about not just our cautions with putting fentanyl patches on, but taking them off and how to dispose them. How do you actually, what do you teach people how to get rid of a fentanyl patch?
Well, you're still supposed to give it a burial at sea. You're still supposed to fold it together, sticky sides together, and dispose of it by flushing. Although I know hospices are using different techniques, putting in a sharps container or something like that. But you've got to be so careful because if a child or a small pet got a hold of a used transdermal fentanyl patch, it could be a fatal event.
Yeah. Speaking of the dosing, are we off fentanyl? You got another one?
We can move on.
I want to ask about oxycodone. And OxyContin in particular, is it a BID drug or should it be a TID drug?
I think OxyContin, in the most part, is a twice-a-day drug. I do want to caution people not to say BID, even though you are saying BID, you are thinking Q12, but don't forget in a hospital, if you say BID or TID, that's different from Q8 or Q12.
Great
but
point.
I think for most patients, it really is a twice-a-day drug. Whenever we're in that situation and it doesn't seem to be lasting, my first inclination is to try and increase the dose a little bit to see if I can maintain that Q12-hour dosing, but sometimes you just can't, and you have to go to Q8. Same with MS-Contin.
I'm going to go back to routes of administration now because we're jumping all over the place. IM. I loved your comment on IM. Oxymorons. You want to repeat that for us?
Yes, an IM opioid is an oxymoron like jumbo shrimp or plastic silverware. So here we're going to give you something to relieve the pain, but it's really going to hurt. So I don't think it's a good look.
Do you ever use IM?
We try very hard not to. I maybe once a year, but maybe not even that often. I mean, I think sub-Q is a beautiful route of administration. And when you look at an equianalgesic chart, sub-Q and IV are close enough for government work, given all the variables that affect that equianalgesic chart, that I think sub-Q is a beautiful thing. The only thing to remember with sub-Q is don't exceed your volume. So people say 1 milliliter an hour is kind of the upper limit. Certainly you can push it to 2.5, but you risk blowing your site. But boy, any hospice nurse in the country will tell you, if somebody blows their access in the middle of the night, sometimes you can talk a family member through reestablishing sub-Q access and not even have to make a visit, but certainly not with IV.
So which of the IV pain meds can we give sub-Q?
Pretty much all of them.
Oh.
Yeah, so we have pretty wide acceptance there. I worked with a resident to come up with a guide for parenteral administration of the top 50 drugs we use in hospice and palliative care, so I'll be happy to share that with you.
Oh, that'd be wonderful.
Yeah.
Any new opioids coming down the pipeline in development that we should be aware of that may be game changers?
I think it'll be interesting to see what happens with the kappa agonists. So stay tuned on that. I mean, I've not heard of anything else that's like, hold the presses, but we'll see with the kappa agonists how that pans out.
All right, I got a buprenorphine. Should we use it?
I think the United States is in some ways behind the rest of the world in using buprenorphine as an analgesic. Certainly, we have Butrans and we have Belbuca. They're both branded products. They're fairly expensive. And there's a pretty significant level of discomfort among practitioners with buprenorphine. It is a partial agonist, but it's got a higher affinity for the mu receptor than the traditional opiates, such as morphine and hydrocodone and oxycodone, for example. So you've got to be very careful. If someone is on a traditional opioid, opioid, you just can't throw buprenorphine on top of it, because you could throw the patient into withdrawal, because the mu receptor is far more attracted to buprenorphine than the morphine oxycodone crew. But you could use any opioid and add it to buprenorphine. So I do think we have some work there. I think it would be nice. I heard that California just came out with a buprenorphine generic that we could start to use for pain that is very cost effective. So I think we're very close to that point, and I would like to see us explore that.
And remind me, partial agonist, what does that mean again?
It means it doesn't bind fully to the receptor, and there's probably, people say, isn't there a ceiling effect in analgesia, where if you're looking at an XY axis there, the more you give of the drug, the more pain relief you get. You go up, up, up. But at a certain point, that line's going to level off, that even if you continue to give more and more drug, you don't get any additional pain relief. But now people are arguing that's a pretty high limit where you start to see that. The good news is with buprenorphine is we probably see a bit less respiratory depression because of this pharmacologic property. So my good friend Dr. Mel Davis is a huge buprenorphine fan. He wrote a wonderful article about 12 things everybody should know about buprenorphine. It's worth a quick read. I think it's a very interesting molecule, and I think we are on the cusp of learning to use it more effectively in clinical practice. And an oldie but a goodie is nalbuphine. And we are seeing people use nalbuphine now for acute pain in the face of the IV morphine, hydromorphone, fentanyl shortage. So something to learn.
So you think buprenorphine is going to be the new methadone, where places are going to like it if it's the cheap generic?
I think there's some hope for using it more routinely in clinical practice. I'm disappointed that levorphanol is so expensive, because levorphanol is very similar to methadone in terms of the properties that make methadone a favorable drug, NMDA receptor antagonism, twice-a-day dosing, but it is a branded product right now, and it's obscenely expensive. It would be nice if we had a generic formulation of that.
Speaking of methadone, I know our listeners and readers probably have a number of questions. Feel free to send them to us, and we'll have a second podcast if you're willing, Lynn. This is so terrific. We have so many questions. Your book is fantastic, and we hope that people go to that as a resource as well. We'll have a link to it on the blog associated with this podcast. But on the topic of methadone, you have a table in the book with 6 different methods of converting to or starting methadone. Do you have... is there a way to simplify it for our listeners and readers? Is there one method that you would elevate above the others?
Sure. The methods that I had in that table are evidence-based methods, some better than others. But I just worked with a group where we came up with a position paper looking at the American Pain Society guidelines for the safe and effective use of methadone, and we applied that to hospice and palliative care. And we came up with a very simple strategy that, frankly, was based more on safety than anything. So anybody on up to 60 milligrams of oral morphine a day, we consider along with opioid-naive patients, and we would start anywhere from 2 to 5 or maybe 7.5 milligrams a day if it's a pretty robust patient. If they're on greater than 60 milligrams a day of oral morphine equivalent and they're under 65 years old, we do a 10-to-1 conversion. So every 10 milligrams of oral morphine is 1 milligram of oral methadone. If they're on greater than 200 milligrams of oral morphine equivalent, or they're over 65 years old, we do a 20-to-1 conversion. But we do recognize the discontinuous nature of this approach. If you go to bed 64 years old and you wake up 65, your organs didn't shut down automatically. So I'm always asking nurses, is the patient a young or an old 63 or a young or an old 67? And the nurses, boy, they are all over that. They completely get it and give me an accurate answer. So I do think this is an approach that we have used I've used this for a long time. It's a very safe way to go. And then we're crazy generous with breakthrough, and we don't use methadone for breakthrough. That's the important thing.
No methadone for breakthrough, because I've heard some people advocate for that, which always seems very scary to me.
Me too. So I would much rather use a linear drug like morphine, for example. I'm not at all a fan of the method where they say, pick a dose of methadone, like 5 milligrams, and tell the patient, take it every 3 hours as much as you need, and then in a week we'll see how much you need. I think that's just looking for trouble. And another important part of that is no matter how much a patient is on, we never start at higher than 30, maybe 40 milligrams of oral methadone a day. And at home, I would not exceed 30. And increasing the dose of methadone methadone, the total daily dose. If they're on less than 30 milligrams a day, we increase by no more than 5 milligrams in total per day, and no sooner than 5 to 7 days.
In total, not going from like 5 TID to 10 or Q8
Correct.
hours. You're going
Correct.
You're going up by like 2 milligrams with each dose?
Yes, and I'm a big fan of the 10 milligram per ml solution. But of course, if you need to, and don't forget, you can go from 3 times a day to a larger dose twice a day and get the job done. Most of the time, we can get away with Q12-hour dosing with methadone.
But once, go ahead.
All right, I got a question on bidirectionality. Like these dose 20 to 1. Am I using this 20 to 1 ratio to go back?
No, unless you're looking for trouble. There's only one paper that's really been looked at, and that's by Walker. And they looked at switching off of methadone to oral morphine, and it worked out to be 4.7. But again, I'm a card-carrying weenie, so what I do is I triple it. I take the methadone dose, multiply by 3, and that's your oral morphine dose. The reason I don't do 4.7 is it's still going to take days to get that methadone out of the body.
Oh, yeah.
So I'm conservative. I'm very generous with the breakthrough, and then and patients get this. If you explain it to them, it's going to take 5 days to get the full effect. It's going to take 5 days to get the drug out of your body. Hang with me. Use the breakthrough. They get it, and they're willing to be your partner in this.
And when we're talking about generous with breakthrough, and you said that several times, do you have a recommendation in terms of like the total daily opioid dose? What? Because I was trained 10 to 20%. I know here at UCSF they generally teach 5 to 15%. What is very generous with breakthrough?
Well, the rule I use is 10 to 15%, but I do think sometimes, and often I will recommend this. When a nurse calls me, I'll say, so when you call the prescriber, here's what you should do. So let's say somebody was on MS Contin 30 Q12, that's 60. 10% would be 6, 15% would be 9. They're both goofy numbers. So often I will ask the nurse to ask the prescriber for 2 orders, morphine 5 milligrams Q2 PRN moderate pain, or morphine 10 milligrams Q2 PRN severe pain. Gives the patient a little latitude there. And often we'll have 2 strengths of breakthrough dosing available depending on what they're going to do. If they have idiopathic breakthrough pain, maybe the 5 milligrams will get the job done. But when the nurse comes to do wound care, maybe you need the 10 milligrams an hour before the nurse comes. And I think if we are seeing a lot of idiopathic breakthrough pain, it's not incident pain, it's not end of dose deterioration. Much of that is neuropathic. So if you're seeing that a lot, maybe that's the time also to add one of those adjuvant drugs.
All right, so maybe for the breakthroughs, having one for moderate, one for severe, for especially those goofy numbers. They're also on a drip of morphine in the ICU. Should we just put a big range, 1 to 10, like knock yourself out, nurses, with going up on it over the next 10 hours?
No, oh my gosh, that's just looking for trouble there. I mean, I have a whole presentation on how to adjust drip. So if you think about it,
a whole
the 3 of us.
chapter in the book on how to do it with great figures too.
It's an important point, and people mess this up a lot, is, hopefully the 3 of us have a normal half-life of morphine, which is about 2 to 3 hours. So if one of us was on a morphine infusion, it's going to take 8 to 12 hours to get 87 to 90% of the way to steady state. So you never want to write an order, nurse to titrate to comfort, because if you keep increasing and increasing it, you're doing some serious dose stacking, and it's all going to hit steady state at 3 in the morning when the patient is asleep and nobody's really got eyes on the patient. You can give the nurse the latitude to increase the bolus dose, the clinician dose that the nurse is in charge of, because the nurse has to do a clinical assessment prior to giving that. But if you do have someone with advanced illness and they're on a continuous infusion of an opioid, the bolus dose that is the PCA that the patient can give, there is a pretty wide range there, anywhere from 50 to even 150% of the hourly infusion. So if somebody's on 5 milligrams an hour of IV morphine, let's just say, the bolus could be anywhere from 2.5 to 7.5 milligrams. Now, I know that sounds a little crazy, but you would only use that crazy dose if you had cut way, way, way back on the continuous infusion, because you really felt you were kind of shooting in the dark. So we often have that in a hospice patient. They're admitted to us, they're on some crazy regimen of maybe transdermal fentanyl, and they're cachectic, and they're on MS Contin, and they're using Vicodin out the kazoo. We'll put them inpatient, we'll add it all together, but then we cut way back on the continuous infusion, but we're generous with the bolus, and we can sort that out within about 12 to 18, 24 hours. So that's, again, conservative with the standing and generous with the breakthrough.
That's terrific. So, okay, I got a question here. What we're talking about, intense sols, we're talking about a lot of liquid concentrations of opioids. Eric and I have wanted to do a taste test about these for a long time. Eric knows where I'm going with this because we have heard from our patients that some of these don't taste very good. But we've been unable to figure out how to actually do a taste test ethically and practically. So
and without being thrown in jail.
Right. It would be swish and spit, just to be clear. We just want the taste. But what do you know about the taste of these different liquid opioid preparations?
I know several things. I know that the opioid liquids all are very, very bitter, and research has shown that the best flavors to mask that bitter are things like raspberry or tutti frutti. And pharmacists routinely have a whole kit called Flavor X, and there are other brands available too, where they can flavor like antibiotics for kids, they can flavor these opioids. So it's really important to ask that, because often patients will say, I'm not taking this stuff because it tastes so horrible. So that is an important consideration. Compounding pharmacists are worth their weight in gold. They often do compounding even for pets. They'll have tuna fish flavor for cats and chicken liver flavor for the dogs. They really can help you quite a bit in this area.
That's terrific.
Well, I think that's fabulous. There is a lot more to learn from Lynn. So she has a great book, again, Demystifying Opioid Conversion Calculations. Lynn, where can we buy this book?
Either on Amazon or ashp.org, which is the publisher, the American Society of Health Systems Pharmacists.
And we will have a link to it on our Jerry Pal podcast. Lynn, again, a huge thank you for coming on.
Huge thank you.
We have a ton more questions for you, so we'd love to have you on. We haven't even talked about things like PCAs and all that other fun stuff, but I think now's the time to end. Alex, would you like to sing a little bit more?
Mm-hmm.
I want a new drug, one that won't spill, one that won't cost too much, will come in a pill. I want a new drug, one that won't go away, one that won't keep me up all night, one that won't make me sleep all day, one that won't make me nervous, wondering what to do, one that makes me feel like I feel when I'm with you. I feel like I'm with you.
Awesome.
And it sounds like kappa agonists are going to be our new drug.
That's right.
We'll need a song for that too.
Or buprenorphine. We'll see. Well, it's going to be a race. I want to thank all of our listeners for joining us this week. We look forward to our next podcast next week. It's with Guy Miko. And do us a favor, if you're listening to this podcast, take a very brief second and rate us on your favorite podcasting software, whether it be iTunes or anything else. Give us a quick shout out. And Lynn, a very big thank you for joining us today.
Thank you so much, Lynn.
Thank you both. Take care. Bye-bye.